All right, so this is going to be your second part of cardiovascular medications. It's going to be about angina, which is chest pain, and arrhythmias. So first, medications for angina from chapter 22. This is going to include organic nitrates such as nitroglycerin, often abbreviated as NTG. So this is going to dilate the veins and decrease venous return, which therefore decreases cardiac oxygen demand, decreasing the need for the heart for oxygen, decreases its freak out that it doesn't have enough oxygen, which is what's causing the chest pain, right? This can also prevent or reduce coronary artery spasms, thus increasing oxygen supply without decreasing demand. So these can have complications though, and side effects. Headache is more of a side effect, so we can do something about that. It's not going to deter us, make them stop taking this medication, but it is a common side effect, so we need to be mindful, probably pre-educate, before we give them. It's very common. You might get a headache, like a really pounding, worst headache of your life almost, but let us know. We can give you something for that. Usually we give them Tylenol, usually cures it up. But also for chest pain, usually we are already giving them like morphine, because that's going to help with decreasing the workload of the heart and therefore decreasing the demand. So then that may cover it. But if they do get a headache, it's perfectly normal. Let them know it might be expected. We can give them Tylenol for it. That's fine. Acetaminophen. Orthostatic hypotension can happen. So making sure that they're changing positions very slowly. This can drastically drop their blood pressure, because remember, it's dilating veins. If it's dilating everything, it's going to can dilate the vessels, which then causes blood pressure to drop. So elevating the feet and promoting venous return to the heart can also help with this, so that their legs aren't dependent, and then they get up and move and it pushes the blood flow, and then their body's like, what is going on? So when they're not standing or doing, if they're in a dependent position, so their feet are down, tell them to elevate their feet just when they remember. Reflex tachycardia can also occur, so monitoring the vital signs. Again, remember, beta blockers are going to decrease heart rate, so if they're having tachycardia, we can give them a beta blocker or a calcium channel blocker to prevent that tachycardic reaction. Nitroglycerin can also have tolerance. So if we're using this frequently on a patient, it may no longer have an effect. So using the lowest dose possible to achieve the effect is going to be ideal. If this is on an IV drip, of course the lowest dose titrated, because too high of a dose, you can drop their blood pressure. So giving them this intermittently, or if they're taking it frequently, then they need to be drug-free of this medication for about 8 hours, just so that their body can reevaluate its life, I guess. So it doesn't become dependent on this medication, and therefore or getting used to the medication and develop a tolerance to it. So then the next time they will have to have more and more of the medication in order to reach the desired effect. For on this right side, I have a little bit of nursing considerations. So sublingual has a very rapid onset, so education here for if they're having angina, chest pain, to rest and take 1 tablet. Don't take a tablet and continue exercising or working out in the yard. Rest and take a tablet. If your chest pain does not be relieved, you need to call 911. During that time, after 5 minutes, if it's not relieved, you can take a second one. If it's not relieved, take a third one. And this is while you're waiting on the EMT to get there. But after 3 tablets, you can't take any more. That's it. So that's very important education about these clients. They're little dissolvable pills that go underneath their tongue, and you see in the picture to the left, this is in a dark vial. The dark vial is to help protect it from the sun. So another education here is to keep it out of the sun. Don't leave this in your car. Make sure that it is covered up and stays at a pretty average temperature, not sitting in the hot sun in the windowsill or in your car. Transdermal or topical use of nitrates are going to be like the cream that we put on the chest with the paper or a patch. These usually have a long duration, and so being mindful of compounding them. So if we give a short and a long, that we might be compounding. So be careful to make sure that all of the medication from the cream, or that if they have a patch on their history, that you have removed all of that extra medication so they're not getting compounded unless the doctor wants them compounded. And then IV. If they're getting nitroglycerin through a continuous IV, we need to make sure that we start the infusion very slowly, and then we're going to titrate it based off of their chest pain. But also, you can only go so high and their blood pressure goes so low as an effect. So you do it to the chest pain, the hope to be relieved, but you also be mindful titrating this with their blood pressure. They're going to be on a continuous cardiac monitoring, and we're going to have a range of either between 5 to 20 micrograms per minute as a rate, and we're going to titrate by increasing by 5. So every 5 minutes, we're going to increase by 5. So if I started this drip at 1800, at 1805, patient still has chest pain, and their blood pressure is still stable. I'm going to now increase it to 10 micrograms because it started with 5. So now I'm titrating it again, so now I have 10. So we're going to do some titrations like that in your workbooks, and you'll have examples of that for your things for lab 2 as well. If they are taking nitroglycerin at home, they should not be drinking alcohol. Also, anti-anginal agents, so relief of chest pain, such as ranoloxine, This is going to lower cardiac oxygen demand, improve exercise intolerance, and decrease pain. However, this can have QT prolongation. So if that interval for the ventricles takes so long to relax, then if it's taking excessive long, then you can become this random arrhythmia. This is called torsades de pointes. See it, know it, recognize it. So it's like a little bow tie or noodle. So it kind of like, in my mind, it like flips back and forth. So it gets big and small and it flips, and then big and small and it flips. It's torsades. So monitoring their EKG, watching for symptoms of palpitations, chest pain, and dyspnea, and then also watching for elevated blood pressure. We're going to monitor their blood pressure. We're going to watch for a raise of 15 milligrams of mercury or more. Then we're going to consider this a complication of this medication because their blood pressure went from 135 to 152. That's greater than 15. This is a result of the medication. And this can be especially more so in clients that have kidney failure because of how it interferes with blood pressure. If kidneys aren't working properly, fluid buildup, and then high blood pressure, and then maybe eventually even heart failure. But during this part, the kidney impairment leading to the high blood pressure, they already have that risk, and then this medication, they have a double risk. All right, this is your second part. So chapter 23 for medications affecting cardiac rhythm. So antidysrhythmic medications can come from a lot of different backgrounds. So there are, of course, the underlying classification specific concerns based on the medications from, your cardio part 1 lecture. So don't forget about the classification specific ones, but if the medication is used for dysrhythmias, these are going to be used to alter the cardiac electrophysiologic response to treat or prevent dysrhythmias. But again, here you have your cardiac toxicity, so widening of that interval causing other dysrhythmias. So monitoring also their medication levels, vital signs, EKGs, and any symptoms of confusion, drowsiness, and vomiting. Pulmonary toxicity and respiratory arrest can also occur. So we're going to get a baseline chest x-ray and pulmonary function tests, and then monitor that throughout their therapy, watching for symptoms of dyspnea, cough, and chest pain. An example of this would be amiodarone. So amiodarone can cause pulmonary toxicity. And then your next one, verapamil, is going to be specific for severe hypotension and bradycardia. We're going to treat it with IV fluids, modified Trendelenburg. So we're going to promote blood flow back to the brain in this position, or IV calcium gluconate in order to counteract this issue that's going on. But remember, verapamil is that calcium channel blocker. So remember, this is kind of one of those specific ones we talked about last week. And so maintaining a heart rate of greater than 50 beats per minute is going to be key here before administering the next dose. Heart failure can also occur, so watching for chest pain, dyspnea, crackles, weight gain, edema. We're going to check their apical pulse heart rate prior to administration, and if it's low, then of course we might not want to give it. Cardiac arrest. This is a stopped heart rate, so they're not perfusing. There's no cardiac output. There's no nothing. However, with adenosine, this may be expected. We're giving this medication to restart their heart. So we're expected to stop the heart for, but it should be less than a minute. It's considered a rest if it does not restart on its own. So with adenosine, this is medication we're going to administer typically, hopefully, ideally, to a peripheral IV that's in the left arm because it's more directly to the heart. As soon as we give it, we're going to give it as a fast bolus, then flush it, and then put their arm above their head. This is going to promote that this medication is giving rapidly and to their heart, and so it's going to stop those channels and stop the heart, and then reconvert hopefully to a normal rhythm when it starts. Of course, as we're stopping their heart, we need to have the crash cart available, and all people, all personnel, the physician, respiratory therapist, nurse, all people on deck when you push this medicine. This isn't just go push it and see what happens. This is like a whole intervention, because if the heart doesn't stop, we need to immediately do compressions and cardioversion and the whole cycle, right? ACLS. So Yes. But so adenosine has these special administration techniques that you have to do in order to provide the desired effect, but make sure your crush cart and people are nearby. And this came from chapters 22 and 23 in your textbook. Thank you.